Hey.
Oye, no, ustedes salieron
¿Qué pasa?
buenas.
¿Cómo está usted?
Muy
Bien.
Te decimos bien,
Bien.
gracias a Dios.
Sí.
¿Y tú?
Tú también.
Esa carita de Margarita.
Tú también.
Recording in progress.
Bien.
How long we have?
10 minutes, and it's already 5 minutes. Goodbye.
1 hour?
An hour.
We have 1 hour together? Oh, that one will be great.
That's too much?
In 1 hour, I can squeeze your brain. Yes, in 1 hour, I can make you cry. It's like some nurses that keep calling me, usually 5, 6 in the afternoon. Flavius, can I change a dry wave?
Oh my God.
Do it. Or even tell me, just do it. Oh, no. Come on, you have to go behind me. Jonesy, be careful with the knee. Your knees. Be careful with them, okay? Okay, let's start. We're good? We're good? All right. Then let's work this way. First of all, every time we talk about best practices, people tend to feel like you're making something wrong and want to correct. It's not that, okay? Best practices for me, and I have best practice all the time. With my bosses, they call me all the time. I'm discussing with them. Is for us to make sure that we addressing the right thing the right way. At the end, guys, we have the same job. Okay, our job is basically take care of our patients and give to them whatever they deserve, which is our best of our knowledge. That's the point. Okay. Then let's discuss some points here today regarding fluids, catheters, infection control. I know you guys hear about that all the time. There's an agenda here if you want to pass by. Natalie, for me, appreciate it. Our first point is going to be about fluids. Okay. And when I mean fluids, I mean that sometimes we are concerned too much about our patient getting a lot of fluids, but sometimes we're not worried about our patients don't having when they don't have enough fluids. And the thing is, hypervolemia is so dangerous than hypovolemia. And we need to know exactly what happened to our patients in one situation and the others. Did you know that a dialysis patient can be dehydrated? They can. Then if that happens, we need to address the same way. Then the first point is, okay, what do I do with a patient with fluid overload? And what happens to the patient with fluid overload? That's my first point. Fluid overload basically means that we understand that our patients, they are not able to remove water by themselves. They are here for that reason. I have a patient this morning sitting here, Miss W, right? This lady, she goes to the hospital every month for fluid overload. I had to move her to 3 times a week to 4 times a week, and it's still not working.
No, listen, projection, she's only doing 3 times. She's not here 4 days.
You see, that's the thing. What caused fluid overload? That's one thing for us to concern. Is the patient drinking too much only? But why the patients do that? Well, number one, remember, most of our patients, they are here, they have as precondition diabetes, okay? And uncontrolled diabetes call for feeling of thirsty. These guys, they feel thirsty, they're not lying, okay? And the patient come to you and say, like, I'm chipping, like you're getting ice chips, right? Well, ice chips is also water. The thing is, the patient told me last week, oh, I'm getting ice chips. So how much you get? Oh, like 4 of this. It's 4 bottles of water, basically. The thing is, how we manage that? Sometimes we are so good on trying to pull the fluids, but we're not that good on educating the patient why he's getting the fluids. Then what I suggest for you, just put your eyes on the glucose levels. Have a second step in the computer and check the A1C. Is this diabetes under control? If it's not, forget it. Your patient is going to be on fluid overload most of the time because he feels thirsty. It's summertime, okay? You go outside right now, it's like 90 degrees on the parking lot, and they feel thirsty like you and me. If you combine this with diabetes, the result is not that good. And what fluid overload can cause? First of all, CHF can really impact the patient. What is that? Heart issues. The majority of our patients, they have heart conditions. All my patients, I bring them to see cardiologists once in a while because their heart gets weak over time. Then excess of fluids, the heart is not able to pump all the stuff. That's the point. Then that's something we need to consider when seeing the patient. This guy, they have sleep apnea, like they increase the hospitalization because the only way to pull their fluids is on dialysis. Sometimes they happen over the weekend, or sometimes he comes here and we're not able to remove everything, or the patient gets what? Cut the treatment. All of this happens. Then one eye on the glucose level, one eye on the patient habits, it really can make the difference when addressing that to the patient. You follow me? The other point is fluid depletion. Fluid depletion, guys, is when the patient doesn't have enough water. And that also happens, okay? Happens when you and me, we pull too much water from these guys. We don't revise the dry wave. We simply let go. I don't like when a nurse call me to say, oh, can I increase the dry wave? Can I reduce the dry wave? Well, that treat numbers, but don't treat patients. You got it? When we simply adjust the wave, we are getting the computer and say, oh, the patient should be living with 97.1. He's living with 99.2. And then I'm going to increase the dry wave to 99. Good job, right? Maybe not, because the patient still have the fluids on him or not. If the patient doesn't have the fluid, okay, that's a good deal. You can increase the dry wave, we're fine. But if the patient has the water, next time Okay, the patient will be here, and the new technician will see what's the dry weight, 99. The patient's 99.5 today, 0.3. Okay, and at the end, the patient's going home with the fluids. Then a good practice would be get your freaking stethoscope, go to the patient lungs, check the lung, deep breath, and you can feel it. Instead of adjusting numbers, we need to adjust patients. In adjusting patients, checking glucose, fluid habits, etc., etc., etc. There's one thing that's very interesting, which is this slide here can show you. This is a study, okay, guys, about how to manage fluids on dialysis. And we have like the UF profile, we have the sodium profile, which when you guys start putting sodium profile in the machine, it freaks me out. And I'm gonna show you why. Adjusting dry weight, blood pressure medication. Do you know that our patients, they don't take blood pressure medication the way they're supposed to? How many times you heard a patient saying to you, oh, I take blood pressure medication when I feel something? Yeah, right? Oh, I didn't feel anything, I didn't take it. You're not supposed to feel anything. Okay, the blood pressure medication is for you to don't feel anything. Then this kind of orientation really helps the patient to self-educate, and at the end, we're reducing hospitalization, we able to manage the anemia better, we manage to make nutrition better. In case you don't know, we draw albumin to measure two things. Number one is nutrition, okay, albumin. But number two, fluids, because albumin is some protein diluted in water. The same thing for anemia. Sometimes you guys call me to say, oh, Flavius, hemoglobin dropped. Okay, the patient is anemic. Okay, but is the patient full of fluids? Of course, these red blood cells, they're going to be diluted in water. Then all of this we need to evaluate as a parameter. I don't know if you guys, have you guys worked with the crit lines before? The crit line, you know what I'm talking about, the crit line? No, crit line is a device that we put on top of the machine, and then we can remove fluids according to the dialysis. The crit line give you a parameter, and okay, the hemoglobin is going up, you can pull more fluids. Then we don't use this anymore in chronic setting. I would love to, because we're able to actually continue to pull fluids from the patient, even with the variances of the blood pressure. Right now, what do we use as fluid removal? We use dry weight, that's sometimes not that accurate. We use the patient, okay, and the blood pressure. That's what we use. Well, blood pressure check what? Every 30 minutes? In 30 minutes, everything changed. Then we should be able to go a little more. And the patients, sometimes they tell us what to do, right? They say, oh, I want only 1.5, but you have 3 on you. All of these, guys, is basically education. Let me show you some profiles that we use, and sometimes I feel that some staff members, they don't know how to use. Profile number 2, for example. What does profile do? This is a time against a fluid repull, okay? Like you have the patient on the machine and how much fluid we're pulling from this guy. Profile number 2 basically says that we start the dialysis sucking everything this patient has. And by the time dialysis is moving, we're reducing the amount of fluid we pull, right? The problem is, do you pull fluids directly from the third space, from the patient edema? No. You pull fluids from where? From the vascular system. Then it's necessary that these fluids move from the third space inside the vascular system for us to take, right? You got it? It depends how fast or how slow this patient has this fluid movement. If the patient has a lot of proteins, good. If the patient doesn't have enough nutrition, bad. That's how the cramp comes. because we start pulling a lot. Then profile number 2 is a great tool for pulmonary edema. Patients dying, okay? You need to, but for regular dialysis, sometimes it doesn't work. It should be better if you use profile 4 or 5. Why that? Because you pull, release, pull, release. You following me? You pull, release, and then you give time for the body to adjust and the fluid to move to the intravascular system, and you're able to take from the patient. That's how we should be managing our profiles. If you don't do anything, you're gonna be seeing you paying people during my presentation. I want my check too. The best way would be we keep like the patient on non-profile at all, or we try to adjust according to what the patient needs. If the patient comes here, he cannot breathe, okay, let's try something. But if you choose for profile number 2, you have to expect that this blood pressure may drop too fast, and maybe at the end, what happens? You give saline. Then everything that you took, you have to put back. That's exactly some management that we do. The other thing that scares me is the sodium profile. Okay, what's a sodium profile? Is when you increase the base of sodium, and then instead of changing how you pull fluids, you give sodium to the patient, right? You made the machine do that. Well, that's simple. The principle, wherever sodium goes, water follows, right? When you give sodium to the patient, you keep the blood pressure at goal. For you guys, that's perfect, okay? For dialysis, perfect. By the time this guy leave here, he's full of sodium, thirsty like crazy. And if you add diabetes, summertime, he's coming next treatment with 4 or 5 kilos. Did your sodium profile work? Nope. You work for 4 hours here. It's something that we have to manage, because when you do too much sodium profile, basically you are condemning the patient to feel thirsty for the rest of his life. The basic line here would be, okay, sodium profile is a measurement that you can use when nothing else is working. Okay, nothing else is working. Well, let's say a patient accidentally took a lot of blood pressure pills before coming to dialysis. Then you can use a combination of sodium profile and profile number 2, UF number 2. You follow? Then you can do this stuff. You're gonna pull the fluids, you force the machine to remove the fluids, but you keep the blood pressure pushing up with sodium. Then there's some biochemistry that you do to your patient that works, but that's when a situation very specific. Okay, this guy, he took too much blood pressure med, and then you have to do something. The other point that is like, is everything okay? You guys get it?
I have a question.
Yeah.
What about the patients that are bottom out pertaining to their blood pressure, 70s, 60s, who are not able to pull or do anything because of the blood pressure?
Well, for this patient, we need to analyze medication. You say like a patient in general is here, come with the low blood pressure. Number
But
one,
the fluid is there.
yeah, number one, check if this patient is on midodrine. Number 2 is, okay, not on midodrine, but he's taking blood pressure medication. It's like antagonic. You give to the patient medication to reduce the blood pressure and something to increase the blood pressure. Then what is he taking as a blood pressure medication? Is he taking blood pressure medication before dialysis? Is the dosage too high? That's when you have to talk to me, okay?
Question again, it's reverse. Patient, real life scenario on fluid management. Patient never comes overload. Patient don't have edema, no signs or whatever. On fluid overload because of the blood pressure. The first thing we're going to do is try to remove fluid. Try to challenge the patient to see if we can get that blood pressure under the range that they want it for. Not able to achieve that. At this point, like you said, communicate to my charge nurse, well, blood pressure needs to be tweaked. because the medication somewhere along the line, the patient is
You
not
mean- you
leaving
mean-
over.
You mean that blood pressure is increasing on dialysis?
No, the blood pressure is not increasing. Blood pressure, yes, it's increasing, it's elevated at
Mhm.
all times.
Mhm.
We're not able to remove fluid because the patient cried, carry on, whatever. Patient is not coming into treatment like, oh my God, you're always coming in overload, or the patient is not going home.
My question
over
for
her
you,
dry
my
days.
question for you is it fluid or is medication?
That's the question now. So
Yeah,
we
yeah,
verified
Yeah.
that it's not fluid,
Mhm.
it's the medication.
Possible with the scenario giving me 100% of chance. It's not fluids.
It's medication.
It's medication.
But the issue
Uh-huh.
is, it's a problem when we say that.
What do you mean?
It's a problem. The person don't want to hear that it's a medication issue,
Well, the
not
thing,
the patient.
I got it. I got
Yeah.
your point. I got a point.
Okay.
The thing is, on my patients, just let me know, Flavius, I have a feeling that this medication related.
Mhm.
And then my job is, well, as I told you, I tell you all the time, reconciliation. Let's reconcile. And let's see what we can be changed.
Mhm.
Then, but what the scenario giving me and is like, it's medication.
Mhm.
It's not fluids.
Okay.
Another misunderstanding that we have on the screen here, you can see, is when the blood pressure goes up on dialysis. And that's something that we call dialysis blood pressure rebound. Is an interdialytic hypertension. If that happens because we increase the venous pressure on the respiratory system. We increase like the pressure in the respiratory system, and the blood pressure overall goes high. That it happens on dialysis. Remember, we're pulling fluids from the third space. And sometimes we do that and we shock the patient with fluids, and the vascular system dilates, blood pressure goes up on dialysis. What's the solution for that? The solution, most of these cases, is we have to increase time. The patient won't like it. But if I'm taking fluids and the blood pressure starts to increase on dialysis, that's exactly what's happening. I'm bringing fluids to the intravascular system, and then blood pressure goes up. 3.5 hours, the patient's over, the pressure is in the roof. We need more time to do what? To take the fluid from the third space and then take the fluids from the intravascular system. Then these are reading that you have to do every single dialysis days. You got the point? Those different situations that you see on our patients all the time, and sometimes you're simply stuck. Oh, the blood pressure is high, let's pull more fluids. That if the patient has 315, 3.5 hours, what we're doing is basically giving hypertension to the patient right here. Another thing that makes me crazy is when I come to the machine and I see temperature 35.5, and I check the blood pressure is like 170, 180. You know what we're doing? We're giving him hypertension.
Yeah.
Because the blood comes from the body with the temperature around 36.7 Celsius, and then we freeze the blood on the machine, give the blood back to him cold, and the arteries do that. Vasoconstriction, blood pressure, poof, goes up. Then that's another thing. Some people they say, no, I keep my temperature lower to keep the blood pressure, but it doesn't work. Then sometimes it's only a matter to see some points and how we manage those points, and we can make them better. The other thing that we have is about infection control. Infection control is really a big deal, okay? And you guys hear about infection control all the time. Everybody talks about infection control. How can you manage infection control? And I have some points here to show you. One of them is this from CDC, is the recommendations that the Center of Disease Control has for infection control. And for dialysis, especially for that, I'm not going to read all of this, but one of the things they really pay attention, and I want to show you here, is about cleaning equipments. It's about touching patients. It's about removing catheters. It's about our standards of touching patients or not. That's basically one of the recommendations from the CDC for us to reduce infection control. Just take a look on this slide. This is very interesting because it shows basically a perspective of how much our patients can get a bloodstream staphylococcus infection. Do you know where staphylococcus live in general? On the skin, okay? When you see, just pay attention because numbers, sometimes they tell us anything. But when you analyze the numbers, when you see the dialysis population, they tend to increase in 100 times a bloodstream infection from a bacterial group. They're supposed to be on our skin. The question is, how in the world these bacteria are moving from the skin to the blood? That's the real question I have to ask. Staphylococcus usually cause cellulitis, erysipelas. Those are the skin adipose tissue infection. That's exactly caused by staphylococcus. But when you have an incidence of bloodstream infections of staphylococcus, what's going on? How this patient get that? That's the question asked all the time. How in the world this patient get an infection, a bloodstream infection for staphylococcus? When I do the blood cultures and come staphylococcus, needles, catheters. Those are the answer. Then let me show you this picture here. Then you know what I'm talking about. Just take a look. These are real patients. This picture is taken by me. Okay, that's just take a look of that. This is basically a fistula, 100% infected, ready to blow up. And take a look on the side here. You see this small scar here? You know what it means? That by the time I have this huge infection over here, somebody was trying to stick a needle right on the side. Actually, was stick a needle. Then what's the issue here? You see, this is the dialysis line, okay? What is the issue here? The issue here is basically we're not paying attention on what happens to our techniques. That's the truth. Okay, we need to face the truth. That's basically technique. Because I do really believe that this infection here is started from like yesterday. Yeah. Here we were basically discussing almost 2-3 weeks. Okay, the thing didn't start away. And this is the patient that actually the thing blew up at home, and this patient died. Because by the time that cover here, okay, this which is infected, you find a spot and opens, it's blood everywhere. And sometimes this patient lives alone, sleepy at night, and sometimes that thing itch, okay, and he's sleeping and starts scratching, and blood, soak it of blood pressure will drop, and he's find Jesus right from there. Okay. This is something, and aside of that, we have the infection for staphylococcus. Then sometimes you guys see me sometimes removing tapes because I want to see what is there. But that's basically a nursing and technician job. If you see something that doesn't look like a well-preserved fistula or graft, communication has to start. Okay, this patient here, I have to send the patient to the hospital. Okay, this patient had like a surgery, a new fistula being placed, catheter for 3 months, blah, 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 just because somebody wasn't giving too much attention for this, and even seeing that was trying to put a needle by the side. That's deep, right? Then that's something we need to work on. in general, CDS, CDC, they have the same type of information for infection control. It's always the same, okay? Hand hygiene, PPE equipment, when the patient cough in front of us, when you cough in front of the patient, not only about COVID, okay? COVID is something that actually you're going easy on that, and it's not bugging us too much, but it's everything. It's everything. Then how we keep our equipment. I'm seeing sometimes needles sitting on the side of the patient, and like on another clinic last week, a patient was playing with a syringe with a needle right there and show it to another patient. Oh, look at this, look at this. Yeah, and what we had there? Well, the nurse, because nurse plays with syringe, not technicians, the nurse went there, gave the medication, put the needle right there at the side of the patient, and left. And now I have a patient play with a needle. Look at that, look at that. And how sterile our equipment is, and everything is basically the same information all the time. I don't know if you guys check expiration date on the equipment every time you're gonna use. That's how it is. Then I would suggest you to actually double check all of those things. Another point that's very interesting is catheters, okay? And here we have to share the culpability because we all guilty on catheters, including me. Catheters, they have to go. Catheters gotta go, okay? And just as illustration, this slide here shows a study that was made in 2011 by all the networks of end-stage renal disease. You know what network is? Those are the guys that actually plans compliance, inspection, the safety of the patient. The guys that come here to give you a hard time, them, okay, yeah. These people, they come here to see how things are doing. That's why have education people, everybody bugging us, because these guys. They had a forum in 2011, 10 years ago, and one of the things that they discussed, that just take a look here. If I don't act to remove a catheter on the patient in 4 weeks, something has to happen. It's my fault. Yes, something has to happen. In 4 weeks, when the patient is here, okay, start on dialysis, in 4 weeks, we need to do something.
Oh, something's gonna happen to the patient.
No. We need to do something. It happened to me, okay, because I'm not acting on that. The point is what actions we can have. Some patient like Miss S, my patient this morning, I know this Miss S from another clinic for like 7 years. She's not going to put a fistula. She doesn't want to. For this patient, what do I have to do? Documentation. If you're curious, go check my note on her. Every single note, patient refuse permanent access. Patient refuse permanent access. Aware of risks. Family contacted all the time. But we need to make sure that our patients, they are very well informed about how catheters work. People say, oh, you have like a permanent catheters. This catheter is not permanent at all. Okay, why? Because catheters, they are not permanent. They're not supposed to be permanent. Okay, it is a device that it put in the patient, and it wasn't born there. It's not permanent, and it's a great source of infection. Great source of infection. One of the goals for CDC for bloodstream infection prevention, just take a look on 6 data they want us to analyze, and look at the number 6, catheter reduction. They want to remove catheter. Why? Because this catheter used to say to the patient, sooner or later, they're going to infect. Okay, our patient, they scratch all the time. I know the majority of our patients don't take a good shower. I know that. Okay, but they do. and they want to clean themselves. Sometimes they go to the beach, sometimes they go to these regular places every human being go and get infected. Then our job is every time we're going to change a dressing, by the way, it's like you cannot have the situation of a person coming here with a catheter and don't have this catheter change every dialysis. We need to have catheter change on every dialysis. And when you're going to change the catheter, sometimes I see people simply cleaning and going. And sometimes I come back and I remove the dressing and I see yellow drainage from there, is redness around. This is an infection forming, staphylococcus there. And these staphylococcus, they have a free way to the heart. Okay, where these catheters are located, like they're located in a vein, they go straight to the right atrium. Okay, the tip of the catheter is right there. That you have a bacteria that is on the skin, and this bacteria group goes straight to the heart. Then, in other words, it's a matter to stimulate catheter reduction. Our patients, they need a permanent access. And at the same time, for the patient that still have the catheter, we still using the catheter, we have to change his dressing every day and look and see what's going on the catheter. Some weeks ago, it's not only permeability of the catheter, it's infection. But you have to look at the catheter overall. Last week, I went to a clinic and then I went to see the patient and I saw the, well, no indicator is like, you feel that it's too long here, okay? And then I removed the dressing, the tip of the catheter is right here, the cuff, better say. The cuff was right here. And then I called the nurse and she said, oh, no, I saw that. You saw the cuff of the catheter hanging over here, and this patient's on the, he can die right here. What to do? Oh, let me return the blood. No, you're not going to. You don't return, don't do anything. Stop it. Send it out. The more hospitalization, more. Just for you to don't think that's only American stuff, but no, it is a study from Australia, renal service, whatever they. When they also work with catheter reduction, they actually have problems. They in terms of insertion, when they're going to insert the catheter, they want to make sure that this catheter are inserted in a proper way in the best places. The same way that we do here in Australia, most of the European countries and Brazil, they avoid to put permanent catheters in the groin because they don't work, it can infect easily over there. Maintenance of the catheter, it means hygiene, educating the patient about having the catheter, and working on reduction. They try to remove the catheter and they say as soon as not required. And when that happens, when the patient has a permanent access. In other words, our job in terms of infection control is to, in catheters, specifically on catheters, is basically saying to the patients that this catheter has a great chance to infect and show to the patient the risk of that, push these patients from to get a permanent access, and you guys push me to do that as well. So if this patient here has a catheter for like 6 months, what's the plan? Okay, and you need to have everybody involved on that. Then, in other words, we covered today fluids overload, fluid depletion, dry waste, UF profile, sodium profile, infection control, washing the hands, using equipment, addressing to the patient, reducing catheter rates. Question. We good?
How old is too old for permanent access?
You mean a fistula?
Mhm.
Old fistula? It depends the preservation. We have studies that show that a graft lives less time than a fistula, but it depends how it is. I don't have any picture here, but I was seeing some of these grafted pictures. The surgeon they have to remove to put a new one. Guys, some of them is like a Swiss cheese. Okay, you have needles crossing the graft here and there, and it's just destroying the graft over time. Then it depends how we preserve. The rules and it's basically the same. We have to rotate the site of putting the needles all the time. I know it sucks because the patient, every time you go to a new site, oh, that hurt. I'm gonna die. And the thing-
that doesn't hurt. Because
Because
they're
right
back in the old
same
spot.
Yeah,
When
and then that
I'm,
causes a
it
problem too.
hurts. It still hurts.
But soon
I think it hurts, it would.
That's what I said, no pain, no gain.
Yeah.
When it doesn't hurt, it's not good. Until the baseball ball here. Let me put it every time in the same spot. The baseball ball here.
And
Oh, no.
yeah, and the fact is, everything is okay until you have problems.
Yeah.
Mhm.
Okay, then if you don't convince your patient that that's the best way to do it, this guy is gonna end up in the hospital. And guess what? You know who's he's gonna blame for?
Mhm.
Yeah.
He's going to.
Yeah,
Yeah,
education. is-
Because
yeah.
when I come, guys, when I come to do my rounds and I see a fistula that way, and I say, "Oh, we need to rotate your site," you know what they tell me?
Mhm.
The nurses, they
Oh,
don't
yeah.
want to rotate.
Yeah.
Oh, the technicians come
Yeah.
here and do it. That's what they say. Then, yeah, yes.
Years
Yeah.
ago,
Look,
years ago.
it's the same thing. It's the same thing when you go to the patient, say, "Well, your blood pressure is high." Oh, the doctor don't change my medication. The same thing. The same thing. That our job is don't be against each other. Our job is as a group, we address that point and show to the patient. The patient doesn't allow, guys, documentation. Okay, call your supervisor. Documentation. I document everything single problem because when if the patient pass, there's always family member that's going to look for our records and see what's there. We
Yeah.
have good documentation,
Yeah.
fine. We don't, we screwed. Okay? We're good? Thank you guys so much. Great, great job, great job, great job, great job, great job. Thank you.
Thank you, thank you, thank you. I wish it was 2 hours, you know? Look, so we don't have to go back on the floor.
Wish